Good. Okay. So um, let's start. So we're going to talk about really priorities and how do you make decisions about these kids with arthrogryposis. And first thing really is to make a diagnosis. Apologies for my dog. First thing is to make a diagnosis. The most common one is amyoplasia, so the most common form of arthrogryposis, and then followed by the distal arthrogryposes, which are a whole set of them. And these are usually autosomal dominant. Um, and then you have anything that results in a contracture of two or more limbs at birth, which is essentially the diagnosis. But if it doesn't fall into one of these other two categories, such as neuromuscular diseases like Amyotrophic, then it's one of these. So I really want to talk about amyoplasia because I think to lump arthrogryposis into one group is a disservice to patients with amyoplasia who have a very specific disease. And the shoulders are typically adducted and internally rotated. The elbows can have flexion contractures, and that's usually from weak triceps, and then extension contractures from weak biceps or both. And then forearms in neutral to slight pronation. Wrists in neutral to deep flexion, and thumbs adducted and flexed. And the fingers can be stiff. MP joint is usually the most preserved. So this is kind of the picture you get. They have cute button noses and particular facies as well. And then you have your distal arthrogryposis, uh, which have variable penetrance and they spare the central joints. And here's an example of a few of them. And um, a whole different picture. If you can see that wrist is an extension, the thumb MP joint is down, and it's a very different look. And each particular distal arthrogryposis has its own um, package, its own look. Here's Freeman-Sheldon syndrome or whistling face. Here's Beal syndrome with these crinkly ears and camptodactyly. Here's multiple pterygium syndrome or Escobar, and that's you get flexion contractures at the elbow. And then there's these other 300 types, which result in contractures. So we're not going to talk about all of those. We're not really going to talk about distal arthrogryposis because it's different than amyoplasia in terms of prognosis, etiology, appearance, function, pretty much everything. Um, in these patients, I will say that you usually need thumb MP fusion and a stiletto flap, and you may need to augment elbow extension. So priorities, really, which is what I was asked to talk about, are in order of age. The first thing we have to think about, and probably the most important thing, is obtaining passive elbow flexion. And that, the ideal time is about 1 to 2 years of age. Then you're looking at shoulder external rotation, and that's at a year plus, and that's handled with a rotational osteotomy of the humerus. And I'm not going to talk about that much because that's a pretty straightforward treatment. Wrist extension is 2+ years of age. And then you're looking at active elbow flexion at 4+ years of age and thumb out of the palm at about 8+. Now, all these are guidelines and not firm rules, and I have broken every one of these rules. So passive elbow flexion, the good is it allows you to have hand to mouth. It allows you grooming, meaning you can wash your own hair, you can put on your glasses, and allows dressing. The bad is there's some kids who use their stiff elbows for upper extremity ambulation. They need elbow extension for bathroom hygiene, and they need their elbow extension to be able to reach possibly their other hand. Give me 1 second while I let my dog out. Apologies. These are the joys of a 16-year-old dog. Okay, so initial treatment is stretching. 80% of kids with amyoplasia will get therapy even into their teenage years. Splinting, nighttime only to encourage use during the day. Serial casting, I think this works better in distal arthrogryposis. And I think the biggest thing to think about when you're going to stretch an elbow is if you have less than 30 degrees of elbow flexion, it's really difficult to determine the axis of rotation. And if that's the case, you're going to end up bending the elbow in the wrong direction. So just be very careful. And I generally do not, I counsel my patients against passive stretching of any kind if they have less than 30 degrees of elbow flexion. So by the time they reach a year of age, if they haven't gained 75 degrees of flexion, then I will consider an elbow release. Contraindications are flexion contractures of greater than 30 degrees on the contralateral side. So if you have that, you may not be able to wipe, and therefore bending the other arm may be a problem. And then if they're upper extremity ambulators, as I said before, the details are pretty straightforward and uh, have been written about by me and others. Ulnar nerve transposition, triceps lengthening, and posterior capsular release. Now, here's some interesting data that's now a few years old. I think it's almost a decade now. Um, we did this paper looking at the age at the time of surgery and the outcomes. And if you look pre-op and post-op, pre-op on the left, post-op on the right, the green represents their motion arc, and the red represents what they're missing from a normal motion arc. And you can see the improvement is quite dramatic when they are less than 2 years of age. Change that to 2 to 3 years of age, and let me just go back and forth what that looks like. And you can see that the arc narrows and you get more of a flexion contracture. But what's also interesting, if you look at the pre-op on the left, you go from 16 degrees to 33 degrees. So this is why I think if they get to 75 degrees of elbow flexion by a year, I'm okay with observing that. Let me let the dog back in. So sorry. Okay. So really interesting that they get more flexion as time goes on, even if you do nothing. And that held up in this data set as well. If you look at kids greater than 3 years of age, 45 degrees of flexion pre-op, and again, slightly decreased arc of motion. So let me go back and forth. If you keep your eyes on the post-op, and you can see this is less than 2 years of age, 2 to 3 years of age, and greater than 3 years of age. And you can see how it keeps declining. So the next goal is active elbow flexion. The good is that it dramatically increases use of the arm. It also improves self-care and independence. And of all the things that I do for kids with arthrogryposis, this is their favorite thing because I ask them all the time, like, was it worth it? And they say, oh yeah, this is the best. So the bad is that all kids exacerbate their flexion contractures with time. Um, and these flexion contractures keep getting worse. So intermittently, I will do serial casting on these kids to keep them from worsening their flexion contractures to a point where they become limiting. So indications are pretty simple: absent or weak active elbow flexion. Contraindications: if they don't have triceps function and you give them active elbow flexion, that's a problem because the flexion contraction will get worse and worse. Lack of meaningful passive motion. So if they don't have passive motion, there's no point in giving them active motion. And I like to see at least a 45-degree arc, uh, unless there's some extenuating circumstance. So if they have an existing flexion contracture of more than 45 degrees and you do a transfer for elbow flexion, they're going to get more flexion contracture, and that's going to be a problem. And then you need to find an adequate muscle. So if they don't have a muscle to transfer, then you cannot transfer it. And there's a need for donor muscle for function. So for example, if uh, uh, if you're going to do a latissimus, but for whatever reason they happen to be a champion rower, you probably don't want to take it. So Tendon and muscle transfers for elbow flexion are all of the below. So the full triceps, which I'm going to go into a little bit, but it is a high risk of elbow flexion contracture. The partial triceps, um, from my friend Scott Oishi and Gloria Gugola and others, limited indications, I think, and in my hands, limited efficacy. And I'm still not convinced that that's a great operation. The Steinler flexorplasty, again, somewhat limited indications. It's rare that patients really have good flexor musculature to use, and therefore the efficacy is not great. The lower pectoralis major, which I actually went to Russia to see um, Olga do, and she has some reasonable results with this. I've not been able to reproduce those results in my patients. Latissimus dorsi, I think, has been amazing, and Olga Agranovich agrees that this is her favorite, and I think this is clearly the runaway best choice when it's available. Otherwise, I think the second best choice is actually a free gracilis or a rectus femoris when available. So here's your bipolar latissimus dorsi muscle transfer and release the latissimus from its origin and insertion. That's the bipolar. We keep the nerve, artery, and veins attached. So it's a pedicle transfer, and we pass it through the deltopectoral interval into the front of the arm. Here's an exam confirming preoperatively that you see a latissimus dorsi. And I do not routinely get MRIs on these patients. I think if you can't see it, you can't use it because this is a very superficial muscle and there's not much else competing with it in that space. We published our results and most patients were able to get at least 3 out of 5 strength, and they were all happy with it. Here's one bilateral bipolars, and you can see really good strength. And here's their other side. There you go. And that's real anti-gravity strength. So here's the lower pectoralis transfer, and you take the lower pec and with its origin and insertion, you keep the nerve, artery, and veins, and you pass it in front of the arm to replace the biceps. So very, very similar, just a different muscle. And you can do this as a monopolar, just keeping it attached to the biceps proximally. Sorry, keeping it attached to the humerus proximally. Then you have free gracilis muscle transfer. For this, you do need to get an MRI to confirm the quality of the muscle because it's very hard to tell for sure because there are other muscles that duplicate its function. Find nerve donor in the arm. So it's great if you have a gracilis, but if you don't have a donor in the arm, you can't use it. I like the pectoral nerves, either lateral or medial, as my preference because they're so easy to use for this particular transfer. Intercostals work quite well. Spinal accessory is a harder reach. And if you have a good hand, consider doing a Oberlin type procedure. Again, surgical details are as you would expect. You harvest, you move it, and then you plug it into the nerve, artery, and veins. Here's an example, 6 months post-op of our first gracilis transfer. This is a few years ago. And she's doing much, much better now, actually. But yes, you can see her still using her back. But then again, it was just 6 months post-op. She doesn't use her back anymore. The rectus femoris was really the idea of Francisco Soldado, who hopefully will be telling us about other things later. And I'm hearing an echo. Oh, okay, good. You really need to have 5 out of 5 knee extension to make sure you don't lose that function, and MRI to confirm availability, generally speaking. Then there's a long head of the triceps transfer. Gloria, Mary Beth, Scott Oishi, Idris, and don't know James Bennett. Move a third of the triceps to the front of the elbow to bend the elbow. I don't think this is effective as muscle transfers, but it certainly is less invasive. And then here's You can tell by the age of the drawing that this is really a historical interest only kind of transfer. And it's still performed by surgeons who are not really up to date with the literature. And hopefully no one on this PULM talk uh, will be doing this in the future. Wrist contractures, pathogenesis, fibrotic shortened muscles, absent wrist extensors, and carpal coalitions. So here's the important thing. You really need wrist flexion to capture and release. You need it for wiping. You need it for eating if you can't reach your face because you have inadequate elbow flexion. And you may need it for weight bearing. You see this child has a callus on the dorsum of his wrist. That is not a wrist that I would consider extending. However, wrist extension improves appearance grasp, but it may weaken finger extension. So I just want to skip since I'm going a little over time. This is carpal wedge. Again, contraindications are really important. Wrist flexion needed to reach the mouth, wrist flexion needed to wipe, inadequate finger extension, and weight bearing on the back of the wrist. Surgical details you can find online. We have certainly videos on little arms. And this is kind of what you get, a 45-degree correction, generally speaking, improved grip strength, improved cosmesis. I'm not going to go over this. I just want to talk to you about this, which is a new thing we're doing, which is you can see this child very, very tight, normally would not qualify for any procedure to extend the wrist. We're doing this at the same time as an elbow release, and I'm just adding a flexor pronator slide. I know it looks barbaric, but the child's pain, because you're releasing all the compartments, is actually quite minimal, and you can see how much more extension we have, both of the wrist and the fingers. So I can tell you now I've done about 10 of these, and the results have been consistently good. So I feel comfortable putting this out there, but I have yet to publish the results of this. So consider it with caution. And then just to say a brief thing about thumbs, there's a lot of thumbs. And I think that's why it's important to make the diagnosis. The one on the upper left is amyoplasia, as is the one below, and the one on the right upper corner is distal arthrogryposis. So my preference is thumb reorientation osteotomy. Indications is your typical thumb in amyoplasia sits in thumb CMC flexion. And therefore, I like to do a base of the thumb metacarpal osteotomy to bring the thumb into more extension. If they don't have any thumb motion and they have inadequate finger flexion for pinch, then it's probably better that they have a thumb to palm pinch, and you don't want to take that thumb out of the palm. Just want to show you the outcomes of this. Here's a girl that I did probably a decade ago. She was I think under 10 at that time. And you can see not your typical thumb function, but really good. And then she sent me this. She's now like 20s, I think. And she's doing she has elbow flexion, which is really important. And you can see her using her passive elbow flexion. And B, her wrists are now reasonably functional, and her thumb is reasonably functional to be able to do that. And you can see there's been some recurrence on the other side, which I think is pretty typical when you do them young. So that's it for now. Thank you so much. And let's get to the questions.
Thank you, Dan. It's a nice picture, nice presentation.
Thank you.
Any questions from the audience? Please upload your questions on the chat. To start with, I want to ask you, does the position of the forearm rotation, whether it is in the mid position or it is in supination, may have an influence on your decision to treat the wrist flexion deformity?
Oh, absolutely. That's a really good point. So I have a whole section in some of my in my longer talk on the forearm. So the forearm is actually really, really important because you need supination and wrist flexion to get to your mouth, generally speaking. but you also need pronation and wrist flexion for wiping, particularly if you're going through the legs. If you're going around the back, supination is what you need. So I think consider the patient's function before you consider what to do with the wrist. And part of that is where the wrist sits in pronation or supination. One of the worst things that happens is these kids end up with flexion contracture, ulnar deviation, and wrist flexion. And they're exactly pointing away from themselves and they can't get back in. So that's a big issue. So for the forearm, if they have no active motion of the forearm, I will usually do a one bone forearm and put them in a neutral position unless they really, really need elbow flexion to reach their face, in which case I'll put them in slight supination if I can put the other side in slight pronation. So they kind of meet. One is pronated, one's supinated, one's for eating, one's for wiping. Does that make sense?
Yes.
Yeah.
But if the patient has the forearm in supination, does the preservation of the flexion deformity of the wrist help him much more? And correction of the wrist flexion deformity may be disabling for him if the
Oh,
forearm.
absolutely. Absolutely. Yeah. So I actually, if you, yeah, I have four contraindications to doing anything to the wrist to extend the wrist. And that's one of them. I think that if you can't reach your face and you need wrist flexion to reach your face, you are not doing anything to straighten that wrist. And so if you look at my practice compared to some of the other practices, particularly in the US, I am very, very reluctant to do carpal wedge on many patients. And I hold to that. In fact, a few years ago, I asked a panel what were their contraindications to doing carpal wedge osteotomy, and no one could name a single contraindication, which bit shocked me.
Very wise. There
Yeah.
is a question. It is how young are you starting elbow flexion splinting and how long typically trying before giving up and operating?
Yeah. So again, I think if you have less than 30 degrees of elbow flexion, do not touch that elbow. So at any age, because you do not know where you're going to go. Now, I'm talking about from a splinting and therapy standpoint. Generally speaking, our results have been much better to do an elbow release at about a year of age. So if if they've not reached 75 degrees of passive elbow flexion by year of age, then that to me is an indication for an elbow release. Now, like I said, these are guidelines. If I see a child that at 9 months was at 60 degrees, sorry, at 9 months was at 30 degrees, and then at a year is at 60 degrees, I'm probably going to follow that child and see how they do because they're making progress, if that makes sense. So if they're having a positive trajectory in their range of motion, then I'm happy to watch it because I know I have till about 2 years of age to get to the elbow. I will never do both elbows at the same time. Having said that, I just did it recently. So I will try to never do both elbows at the same time because you end up with potential for elbow flexion contractures on both sides, which would be problematic. So I think the timing for anything is whenever you first see the patient, try to do some passive range of motion if you can, up to about a year of age. After that, I think your passive motion for the elbow is going to be of limited use. And then you're looking at surgical options after that age. The other thing I'll say is from a after they get to about 8 or so, it's really, really, really difficult to do an elbow release because the elbow is no longer round, meaning the articular surfaces are no longer a circle. They become more elliptical. And as such, motion becomes really, really difficult. I'm not saying that in every case, but I've seen several times. So results are very unpredictable.
Soldado's asking, After what age wrist thumb surgery is indicated?
Yeah. So again, these things are so wrist, I think, doesn't really matter to some degree. The younger the child is, the more likely they are to have a recurrence, I think. However, you can give them a lot more years of function if you do it at a younger age. And so I think that if you are willing to maintain the child in a splint nightly, pretty much for their entire childhood, then I think you can do it at an early age. If and I think that particular patients who have who have finger MP hyperextension, I'm really aggressive with bringing the wrist into extension to get those MP joints down so they can have better hand function. Because if they look like that, right, and you can bring their wrist up, their MP joints come down, and they're much more functional. And you can take a child that has no hand use and give them hand use. And I think for the thumb is sort of similar. I try to wait until they're at least 8 years old because of the thumb remodeling. And what happens is you bring the thumb into extension, you're really happy with where it is, and then over the years it comes back down and it just remodels into flexion. And that you just don't, some of these kids, you just don't have any thumb extension actively. And so it's really a positional transfer or a positional surgery, and those will change over time.
Dan, it's Dave Makuma. The decision about releasing the elbows early. Do you think the kids it's not clear whether they're going to be dependent on their triceps function for ambulation, which at less than a year is probably hard to pick, isn't it? There'll be some who it's very clear that they're going to be dependent on their triceps for transfers and weight bearing, but there'll be a pretty big group who I think are hard to know what they're going to be doing.
Yeah, yeah, yeah.
Do you think you downgrade them by releasing their elbows early? And I accept that it's better to do it early, but it's always a bit of a tortured decision as to, am I doing this kid harm in terms of their lower limb, their transfer capacity, their ambulation for the sake of a little bit of extra elbow flexion?
Yeah, no, I think that's a really good point. I would say that it is super rare that I release an elbow at 1 year of age and they get a meaningful elbow flexion contracture. So
And their tricep strength is maintained.
yeah, their tricep strength comes back. So
Yeah.
the tricep strength is more variable in terms of return when you get older.
Yeah.
So I'm not as tortured by it because I think so far my results have been pretty consistent in terms of at a year of age. If I go 2+ years of age, it's a grab bag. Like I just don't know what I'm going to get, and I get very concerned about exactly what you're talking about. Um, and then when they show up, I get a lot of people showing up from wherever,
Yeah.
right? At like 8 years old. I had one kid the other day who's literally he walks around on his hands and they want the elbow released. And I said, no, you need that, right? It sort of sucks. But I don't recall any patient that I've ever done, and I'm sure there's one that I'm not aware of or several, but I don't recall any patient that I've lost the potential for upper extremity weight bearing on a release I did at a year of age.
So in terms of that exclusion criteria, so your indication's less than 75 degrees, but your exclusion criteria in terms of uh, ambulation, you're really restricting that to the kids who are absolutely quadrimembral amyoplasia, and you think are very much going to be, or would you even do it if you're not going to lose anything by doing it in that early age group? You would do it anyway, even in those kids.
Yeah, yeah, exactly. I think if you get to it really young, the results are quite consistent. And I do more of a triceps slide than in addition to a a V to Y kind of lengthening.
Yep.
Scott Rishi does a W. I find that to be a little futzier for me. Um, but I think what I do is I elevate the entire medial head of the triceps. And I find that when I do that, I can get back up to the olecranon without a gap, if that makes sense, or maybe a
Yep.
centimeter gap, something like that.
Yep. Yep.
So that to me, I think that's one of the reasons why I'm able to maintain triceps function is basically your medial head becomes that sort of initial mover. And I've restored the length of the triceps fully. If that makes sense? If you don't
Yeah.
do
I
that, you
no.
end up with a big gap like this, um, if you don't mobilize the medial head.
Okay. Thank
Yeah.
you. That's great.
Thanks,
We
Dave.
have a, we have a question. When there is no finger motion, how can we improve autonomy?
Yeah. Uh, I think if we had Elon Musk kind of money, we we would just build an exoskeleton. But yeah, we don't I don't think there's really much you can do. I'm always surprised at how much they do with no finger motion and how they cram things into their hands or they don't. I have a lot of these kids who just have these arms that just do this, and they will, like a complete amyoplasia patient that has absolutely no musculature in their upper limbs will have everything in neutral. So their elbows will be in about 60 degrees of flexion, which is kind of the neutral position. Their forearms will be in neutral, their wrists will be in neutral, their fingers will be relatively straightish, like this, and their thumbs will be reasonably straightish. And they just kind of do this. And their thumbs are kind of in a resting posture because everything's gone, right? And they manage to sort of put their hands together and hold things. And I'm amazed at what they can do. But I don't have any answers to that. If somebody has an answer for that, I will visit you and forever sing your praises.
There's a question from Soldado. In very tight, extended elbows, that does not have concentrical joints with fulcrum after 70 to 90 degrees. Have you found that? And is that a reason to lose some of the flexion gained at surgery, not to blame therapists?
I'm not sure I understood the question.
Uh,
Maybe you can read it by
Hassan,
yourself at the chat. Can you?
Maybe. Let me go to the
go on,
chat.
Soldado.
Dan, in really tight extended elbows, when you release the elbow, after 70, 90 degrees, there is a anterior fulcrum.
Yes.
So the joint is not concentrical. And I guess that's a reason why you lose the flexion you gain during surgery. Have you found that?
Yes, that's exactly true. So what happens is because you've not been in flexion ever, you don't have a coronoid fossa and you don't have a radial head fossa. And so what happens is that when the coronoid hits the anterior humerus, it forms this anterior fulcrum and it opens up. That's what you're talking about. And the whole joint just does this. So I don't release beyond that point. Once it starts to lift off, I just stop, right? Because there's no point beyond that. And usually that's at around 90 degrees, maybe 100, right? And so I don't try to get more than that if I don't have, but sometimes you can get 120 degrees at the time of surgery without that lift off. But yeah, I think that's one of the reasons why you lose flexion that you gained at surgery. Clearly, if the reason you have 160 degrees of flexion is because the whole elbow is hinged on the coronoid, then you're going to lose that as soon as the elbow reduces. Yeah. No child is going to allow you to move them into dislocation of their elbow while they're awake.
And the oldest the patient, the worse it
Yes.
happens.
Yes, exactly. This is very true. And what happens, as I mentioned, the capitellum and the trochlea go from being sort of round to becoming more elliptical. And they're actually sort of from proximal to distal, they're elliptical, longer. And so when you try to rotate around that, it lifts off right away because it's not concentric in any way. Yeah.
I want to ask you about the surgery you do for sliding of the whole pronator and the flexor. What is different in these patients from other muscle sliding release done for other pathologies?
Yeah, so I think one of the big sort of points about amyoplasia is that oftentimes, so there's a distinction between kids who have no muscle, kids who have some muscle, and that's a big thing. So if you have no muscle, you still develop a tendon, and that tendon becomes a ligament, if that makes sense.
Yes, yes.
So a string of collagen that goes from bone to bone is a ligament, right? If there's no muscle in between. And so what you see in some of these kids, particularly the FCU, it'll just be, it's nothing. There's no muscle whatsoever. So as you're doing that operation, you're looking for musculature. And oftentimes you find not much. And so I think that just removing that from the bone and cutting all those Sharpie's fibers and getting all that tendon off basically is like doing a ligament release for the forearm. And then all the musculature, the other thing is what you see is in amyoplasia, if they have some muscle, they're able to grow more. But if they have no muscle, that's it. It's like it's game over. So you have a really good sense when you do that release that the flexor pronator slide of what you're dealing with, which is really nice. I think the other thing that's really interesting about the flexor pronator slide in conjunction with an elbow release is because the whole ulnar nerve moves with the flexor mass, they end up doing better in in terms of their elbow range of motion, and they have less pain during rehab, which is really interesting. So after I started doing that, then I started not formally transposing the ulnar nerve. I would transpose the ulnar nerve, but even when I don't do a flexor pronator slide, I no longer secure the nerve with any kind of suture from fat to fascia or anything like that. I just let it fly because you're going to sit in elbow flexion for 2 weeks anyway in the post-op, and that's enough for that ulnar nerve to sit comfortably where it's going to be. And I think what ends up happening is every once in a while you get a stitch into the medial antebrachial cutaneous nerve or a branch of, and that's really painful and they hate it. And that's when your therapy goes to crap. And I think those are the patients that have done really poorly. I had one patient that was done by one of my partners that that had a medial antebrachial cutaneous nerve with a suture on it, and we released that, and the patient got better. It's really interesting. So I don't do it anymore. I'm sure I've had a ton of patients that I did the same, right? So yeah, I think that limits you.
Okay. There is no more questions. Thank you, Dan, very much for this presentation discussion.